So I'll get straight to it. So I'm going to talk about some key findings from a collection of little projects that have come from a practice research network called SCORE. So the logos at the bottom are currently the universities that we're working with, as well as a couple of professional bodies. What I particularly like about this network is that we're working with the counselling and mental health services of these universities. So it's very practice-led to make sure that the research that we're doing is hopefully going back into evidencing. We talked about the mental health charter earlier and making sure that we're evidencing the support services that we're offering, so it's very much driven by practice. So we were quite fortunate that this group got together back in 2017. We did not know a pandemic was going to hit, but basically we got together because there were a few trends that we were seeing in the sector in terms of the provision of student mental health services. And one of the things that we were seeing a lot of back then is this idea of a media-led narrative. So we talked a bit about language earlier as well. Now we need to be careful about the types of terms that we're using and clear whether we're talking about mental health, mental ill health, well-being. All of these areas are really important, but when we come to research in these areas, when we're trying to write policies about how universities should improve their mental health services or improve the wellbeing in the curriculum, when it comes to evidence in that, we need to be really careful about what we're measuring and make sure that we're measuring the thing that we think we're trying to measure. So I just wanted to put this up here to show a bit of a contrast to see how confusing it might be for students even before they come to university. So in one article, they're being told, pretty much if you come to university, you're going to experience a student mental health crisis. And then another article, we're saying, okay, well, we'll react to this by looking at well-being. So we think we need to be really careful when we're talking about researching these different areas and promoting more of a holistic approach about looking at all of these different areas rather than putting out these buzz terms. So we wanted to try to address the sort of evidence side of things by looking at the data. So the issue with language, we also see in some of the media and some of the research that we're doing, it's very difficult to know what it is that we're measuring when we talk about well-being and what are we measuring when we're looking at whether a mental health service is effective or not. And so one of the ways in which we thought we could address this is just by looking at the data that's already captured in routine practice in our mental health services. So we did a 1-year sort of proof of concept study where we just looked to see is it possible to collate routinely collected mental health data from university counselling services in an acceptable, confidential and anonymous way. Can we collate that information to generate a robust and a larger and a longitudinal UK student mental health data set? Because one of the benefits of doing that is that what we're starting to see with some of the talks that we've already mentioned today is it's really hard to look at outcomes for students from underrepresented groups when we're only looking at one institution. So a benefit of involving lots of different institutions is that hopefully we can start to grow smaller subsets of data where we can look at outcomes from students that we wouldn't naturally see in a standalone institution or a standardised service. And through looking at this data, aside from being really, really messy and a really steep learning curve, we started to notice that there are no UK standards for mental health services embedded into universities. There are no data standards giving them advice about what they should collect, what students think are acceptable in terms of when we're trying to characterise them, and what measures should we be looking at when we're determining whether a service is effective or not, and the measures that students are completing when they're coming to receive counselling or psychotherapy or another form of mental health intervention. There's no advice about what measures to use or why. So at the heart of this sort of little consortium, we basically just want to strive to improve the data standards in terms of what's collected in our university support services. And there are a number of different ways in which we're trying to tackle this. So starting from the top, we've got the sort of background activity of just churning the data, just trying to pull the data that's routinely collected from our mental health services. We've been clear to use different measures and different systems because we've talked about a lot about how realistic we provide a recommendation, but in practice, is that realistic? And the reality is that in the UK, services use different measures, use different computer systems, they have different levels of training, they use them in a different way. Some of them embed them into the psychotherapy, others do not. Some of them use them at the start and at the end. So for those individuals, if they've dropped out, we have no idea what's happened to them or why they've dropped out because no information was captured on them, and other universities use it every session. So we knew, although it was going to be really, really messy, that it was important. This is how the practice is, this is what it looks like. So we need to do research that allows us to ideally improve some of these practices based on what we've got already. So we've done a lot of mapping of the data. This has helped us to identify some gaps, so where are there missing areas of information. We've taken this back to students and practitioners in the sector to try to consult them, to figure out why there might be some gaps in terms of basic things like demographic information, how are we characterising our students, what's acceptable to collect and why. So we're trying to complement the quantitative data with some qualitative exercises to see how we can, if we were to develop training to improve data standards, how might we go about doing that. And then the last section is that if we are able to identify any recommendations, we can't just expect institutions and universities and services to just go ahead and do it in the little time that they have. They need support in implementing those changes, whether that be training, whether that be funding, whatever that may be. So when we formed, we were actually just focusing on what we call routine outcome measures, or ROMs. So these are measures that were already collected in the service, just to see year on year how are our students and their mental health in terms of when they're at the point of approaching counselling, how is it looking over time. But actually what we found is that there's a lot more to it than just that. And so we started to develop these other projects alongside, where we're looking at the impact that counselling may have on students' ability to perform academically. We're also starting to consult the sector to figure out what data is missing. So of the characteristics that we are collecting, what areas would it be helpful to inform and shape services? So what data is not there? And then because COVID happened, we were really quite fortunate that a handful of the services we were working with, despite dealing with a pandemic and obviously then shifting to online therapy, they were able to continue to use these routine outcome measures. So we were able to compare how the service did, if you like, how good was it during the pandemic versus before the pandemic. So not only does this tell us about the service, but this also gives us an opportunity to inform decisions moving forward. So we've got a lot of people doing hybrid working right now, and there's a lot of uncertainty amongst our support services about whether they should just go back to delivering face-to-face counselling, psychotherapy and mental health support, or whether there is a need for certain types of students that might want to have an option of having online therapy. So some of the data that was collected can be used to inform and shape these decisions in an informative way. So I just wanted to show you a snapshot of the first year of the data that we pulled from. This was only a handful of services. We're now fortunate to be working with 8 services across the 5 years, but this was year 1 working with a handful of services. I just wanted to highlight the red boxes here to show that even in 1 year of working with a couple of services, we were already starting to see sample sizes of students that we would not usually see in a standalone counselling service. We wouldn't have nearly 1,000 students, 1,000 male students in one university counselling service to see what type of issues are they experiencing and how effective is that type of intervention for those types of students. So just to say, moving forward, we're now starting to look at different cross-sections of the data to see how different student groups are approaching. Are there still some that aren't responding well to counselling psychotherapy, or are they dropping out, and what can we do about those certain types of students who may be dropping out of, whether it be dropping out of university or just deciding that therapy isn't for them at that point. So I didn't want to bore you with loads of graphs. I've just bullet pointed some of the key findings here. It's probably echoes a lot of what we've been talking about today. But what's interesting is that the first year of our data set was done back in 2017, so way before the pandemic hit. And despite it being before the pandemic, when we compare the levels of complexity, so how many types of presenting issues students are bringing to counselling, whether it be anxiety or depression or academic distress, the severity of those issues and the complexity was already more sort of higher clinically than published cohorts from pre-2017. Unfortunately, we haven't yet looked at the data from the COVID year, but we've got some preliminary findings that are quite interesting, which I'll talk about in a minute. When we look at outcomes, we see that counselling was particularly effective for a range of areas. I just wanted to highlight this last one around academic distress on the second bullet point. Because again, going back to this idea about it's great using clinical measures, but counselling or mental health interventions impact more than just a student's ability to thrive at university. It might have an impact on their academic output as well. What we found was quite interesting, but not surprising, is that because our services did collect data every session, it meant that when students decided that counselling wasn't for them, or they dropped out, or they took a leave of absence, we had information on those students, so we were able to see how their outcomes were compared to those that had a planned ending. So basically, those with a planned ending are our best outcome. So when we're working with services that are only able to capture pre and post, and we're only able to report on those with a planned outcome, that's the best case scenario. So we're really trying to support services to try to use these measures every session, because we know that when we look at that, is that actually when students are dropping out, it's because they are having poorer outcomes. So there's something that we can do about that, but only if we've got the data to know what's going on with these students. So when we look at academic outcomes, this is led by a particular researcher at BACP. So he's looking at a sort of questionnaire called CHOW, which basically looks at the impact that counselling might have on academic outcomes, self-report from the students. And basically, it asks a series of questions before counselling and after, but we're working with services to use it every session as well. And broadly, what we see is that when students finish counselling, they feel that it had a significant reduction on their problems. So the mental health problems that they bring into counselling are significantly reduced when they leave counselling, whatever type of counselling they might have received. And they acknowledge that counselling is one of the many factors. So it's not just mental health services, it's this wider sort of mental health and wellbeing agenda that is helping students to thrive at university. And so one of our take-home points from this is that there's a lot of value in collecting what we're calling other data. When we're looking at our mental health and wellbeing services, we need to look at sort of academic and independent learning measures as well. What we found most interestingly is that the services that were able to continue to use these measures during online therapy is that our intake profile was very similar. So still seeing a lot of that academic distress coming through the door, a lot of anxiety and a lot of depression. In bold, we've got social anxiety, because in the research that we've been doing over the years, social anxiety is not a common issue that we see students bring to counselling. However, during the pandemic, not surprisingly, this was clearly a growing issue. What was interesting, and I'll take this with a pinch of salt, but the third bullet point, there was a lower severity at intake for our students that approached counselling services during COVID, before the pandemic. And this doesn't necessarily say that they had lower issues. When we look at the data in terms of how long they're taking to wait or seek help, we noticed a strange pattern where it seemed like students were accessing help sooner when therapy was available online, which we thought was particularly interesting. And when we look at improvement rates, we have near on the same improvement rates for that particular service. So students were reducing their levels of anxiety, depression, lower levels of academic distress when they were leaving counselling. So a bit of a clap for counselling services, because despite all of the challenges, these particular services anyway, lots of caveats here because we only worked with a couple, but these particular services, they were able to evidence the fact that they were effective when they were working online, and they were only able to do that by collecting this robust data. But it also poses some questions moving forward, because there is a hint there that there are certain types of students that might still benefit from online counselling, but that's not to replace face-to-face, and it's not to replace all of the other types of resources that we have available. But it's just to flag the point that it's really important to be using research to not only evidence the interventions that we're offering, but to use it to guide the decisions that we're making and where the funding is going. It doesn't quite fit on there, sorry about that one. So this piece of work is also led by Jenny O'Donnell at BACP. This is our qualitative work where we've looked at the issues that we've seen in the data gaps and we've taken it back to students. This is actually our staff data, but we've done student consultations as well from 26 universities. This is our first messy stage of trying to develop some sort of minimum data standard if we were to advise what services could collect. And they're falling around these 4 domains. So demographics, how are we characterising students, clinical or academic outcomes, and how are we evaluating or evidencing our services. So just to finish with some of the lessons learned from this little network that we've been working with over time, is that actually there's a lot of value in using measures every session. Few services do, and there's lots of reasons as to why that is the case. There are many challenges. Seems quite straightforward, but there are many challenges to using measures every session. But it's also important to look at this other data, so not just mental health or wellbeing outcomes. We need to be looking at sense of belonging, loneliness, isolation, their ability to function, learn independently, all of these other areas as well. What was interesting is that although this came from just the data that services collect, so the data quality is better if you capture all these areas, when we talk to staff is that they were actually agreeing with the recommendations, but they recognise that there are huge challenges in doing this, and there are lots of cost issues associated with using certain measures. And so some of the ways in which we learned that the services were doing well, that were using measures every session, is that there was a really positive culture around using measures. And it wasn't just seen as a paper filling exercise, it was seen at how can it be used to inform the awareness of clients when they're going through therapy. In the broader psychotherapy literature, we can see that we can improve or enhance outcomes by embedding feedback from some of these measures into the counselling and psychotherapy. So it's about really thinking about the measures and what we're doing with the data and when we're working with students. Just a point as well, the data that services are naturally collecting as part of their running their service and evaluating it, it seems to be reliable and it seems to be robust. And so far it seems to be feasible to get these services to work together to try to generate these larger data sets to look at these underrepresented students. And again, with the idea of being able to inform decisions about hybrid working or online therapy or offering a mixture of both, these services were in a position where they could use their research and use their data to make a decision about whether they were less effective during COVID and so maybe they shouldn't offer online therapy, or whether there's certain students that they're working particularly well with. Why are they working well with those students? What can we learn from about the staff working with those students that we can perhaps train to other practitioners working elsewhere? And just the last point I wanted to raise is that although some of the measures we're looking at are broad measures like the core OM or CCAPs, which look at lots of different domains. We also work with specific measures like PHQ-9 for depression and anxiety. But a lot of the data that we've looked at so far are from these broader measures, and what we've really seen is that there's value in using these broader measures because we didn't know the pandemic was going to hit, and so we didn't know that the intake or the issues that students bring to counselling were going to be more than just anxiety and depression. We're seeing a lot more nuanced sort of presenting issues coming through. We wouldn't have captured that if we were only using domain specific, so only using a depression on it, a measure on depression, or only using a measure on anxiety. So there's a balance there between not overburdening students and asking too many questions, but also what are we missing if we're not looking at academic factors or isolation factors or some of these other factors, particularly as we're seeing different trends coming through the door after COVID. So this is just the website for the network if anyone's interested in getting involved, either as a researcher, a student, or a practitioner. We've got loads of research placements with this group at the minute, and here's our Twitter. But thank you all for listening.
I think this was actually brilliant. You've kind of covered it all now. And so interesting, and I think for our counselling services obviously as well, it's something we've been, Jessica kind of, isn't it kind of how do we measure and your kind of clinic.
Yeah.
And I think it's such an important thing. Thank you very much. Are there any burning questions? You have to talk right now.
Yeah, I've got one very quick and very practical question. Am I right in thinking that because you're using data that is collected as part of standard clinical practice, you don't really need to get ethical approval for analyzing? So it's from that perspective, it's a bit easier to get a hold of.
So so technically, according to GDPR, you do not need to, but we felt as if it was appropriate to make sure that ethics was in place at each institution. So we've left that decision up to the institution. So we have blanket ethics from the University of Sheffield, because when we started, it was just looking at the routine outcome data, but now we're consulting students, talking to staff, we're doing an intention of moving forward, of having this data contribute to a larger data set. So technically we don't, but we felt it was more appropriate to not only get ethics approved, but also it's stated in client contracts and consent forms that they can opt out of contributing their data if they don't want to.